So thank you for the nice introduction. Our talk is about fiber optic sensor-based guidance system for epidural catheter insertion. Excuse me. I slightly updated the content of the presentation because by the time of submission to the time of talk, we kind of had a couple of new prototypes. So, excuse me. So we are going to have a few new data in the presentation. This work has been mainly done by a couple of our students, particularly Aidana, who was not able to be here, and Aizhan. And they have been working on a fiber optic sensing technology for guidance system in epidural catheters. So an epidural catheter is kind of sketched right here. It is a catheter with a 90-degree turn on the tip in order to be able to inject the anesthetic fluid inside the epidural space, which is located behind the ligamentum flavum between the vertebrae 3 and 4. So the anatomical model that is sketched right here kind of shows the insertion place. The catheter starts from the skin, penetrates through a layer of tissues that have different consistencies, and finally reaches the epidural space that is located behind the ligamenta flava. Now, one common problem in medicine is that there is a possibility that the insertion doesn't reach the target. So that can happen because the insertion is done by a clinician. In particularly, epidural anesthesia is common for deliveries of babies for women, and that means that the procedure is highly risky. And there is a generic problem of the clinician, particularly an experienced clinician, in delivering the insertion of the catheter perfectly to the epidural space. So what we try to do in this work is a guidance system that is able to tell the clinician in real time whether not only the catheter has reached the epidural space, but also whether it is going to reach it. So to try to prevent possible failures that can happen during the procedure. There have been several technologies that have done that in the past and that are doing nowadays in clinical practice. In general, the monitoring means that we verify that the epidural needle has reached the epidural space. There are several technologies to do that. The hanging drop technique is the oldest one and kind of mainly used in clinics. And relies on the fact of inserting a very small amount of liquid and detecting the pressure on the tip of the needle. Whether the needle has reached the epidural space and the tissue has changed consistency, we see an increase of pressure. There is a method called loss of resistance that does a similar job, but kind of detects the loss of resistance through every layer. So it is able to detect the progress of the catheter through each layer. And a more recent work that was presented by a group of University of Sannio in Italy that is based on fiber Bragg grating, so optical fibers, is based on a technology based on FBG. The FBG is mounted nearby the tip of the catheter, and when the final layer is reached, peak pressure is observed. This method is considered to be quite reliable because it detects the pressure throughout the whole insertion. So it sees two pressure peaks, one when the catheter passes the first ligamentum and one when it passes the ligamenta flava. So after that drop of pressure, we can say that we have reached the epidural space. Now, the main problems of all these techniques is that they do not tell the information about whether the catheter is going to reach the epidural space. There are some cases where the catheter, for example, is bent by the clinician by mistake, or whether the catheter is rotating in the tissue by mistake. And this might lead to a failure in the procedure, particularly because the catheter that has some limitation in the stiffness might bend throughout the insertion and therefore might not reach the target. A simple measurement of pressure probably is able to tell only when the catheter has reached the epidural space. That is where the change of pressure is recorded. But what happens throughout is something that we have tried to investigate in our study. So the other problem of some of these techniques, particularly the one based on FBG, is when the FBG is mounted inside the catheter and locked to the catheter, usually using epoxy, then we partially obstruct the catheter wall. That means that the delivery of the anesthetic fluid has to be adjusted. In fact, this work has presented the sensing part, but yet it does not present the data about whether the delivery of the anesthetic fluid after the catheter has reached the space is going to happen correctly, or whether there are limitations about that. So what we try to do is to use fiber optic sensors that have two characteristics. The first one is that they are mounted outside of the catheter wall and fixed with epoxy. We tested several solutions in order to find an epoxy that is working correctly for this type of insertion, and not inside the wall. And it detects the strain occurring on the catheter, not in a single point, but in multiple points around the catheter. So to do this, we prepared a setup that has two sensing units. That's the main difference between the proceeding that you will find and what I'm presenting right now. The first one is an array of 5 Fiber Bragg gratings, which are mounted on the side of the catheter. That's the tip of the needle, which is 90-degree turn. This needle has about 8 centimeters in length, and we have an array of 5 FBGs that are mounted with a spacing of 1 centimeter each on this side. The second technology that we have used is distributed sensing, which is based on optical scatter reflectometer, this instrument right here, that is able to detect the Rayleigh scattering spectrum throughout the whole length of the sensing region, which has been set to 8 centimeter with a resolution of 1 millimeter. So it kind of have 80 sensors within the 8 centimeters length of the catheter, and is able to render strain data versus the distance. So what we did was to prepare a phantom that has several layers of meat that mimics, in terms of consistency, particularly Young's modulus, and thickness, the several layers of the epidural space. We just were not able to mimic perfectly the last layer, but we kind of made insertion where the catheter has failed to reach the last layer to verify whether we do not see the final pressure peak happening. So that's kind of the experimental setup. The two fibers are interrogated by two different analyzers, one based on a superluminescent LED and a spectrometer, standard FBG interrogator, and the distributed sensing system based on the backscatter reflectometer from Luna. So this is the view of the phantom. There are multiple layers of meat. There is a jelly that has been prepared and solidified up to the point that it mimics the consistency of the interspilous ligament. Then there is a final meat layer and a final jelly layer, which presents basically the soft part. This is where the highest pressure peaks are recorded. And then, of course, we have the bottom of the beaker. Now, the match between layers has been validated on another phantom, which is a proper medical phantom. We try to mimic that technology in a low-cost phantom that we could use to perform hundreds of experiments without having to throw away hundreds of medical phantoms. This is the view of the catheter, and this is the location of the 5 Fiber Bragg gratings that we use for our experiment. Of course, we do not see the distributed sensing unit because in distributed sensing, the fiber itself acts as a sensor. So we do not have a precise location of the sensors, but rather we do see the whole scattering map. So the data are rendered in a way that we call strain map, where we report for each type of insertion and for each type of measurement, we report the data in terms of strain as a function of distance from the fiber and time. So on the x-axis, we have time. On the y-axis, we have the distance from the tip of the catheter. And the color is strain. We call these strain maps because they actually represent a strain distribution. So that's how we interpret the data in order to understand what happens during the insertion. So at first, since the data are sampled, both in space and time, we introduce the concept of sampling. For the FBG, since each FBG has a distance between sensor and sensor of 10 millimeter, we can say that the spatial sampling is 10 millimeter. While for backscatter reflectometry, the resolution is 1 millimeter, as we set on our analyzer. And the time sampling is 10 milliseconds for FBG. That's the time it takes for the spectrometer to perform one measurement, while the OBR is much slower, about 0.3 seconds in terms of response time. So we have a signal that is sampled both in space and time. We have a slow sampling in spacing for FBGs, but fast in time, and a fast sampling in space for OBR and slow in time. So we kind of have two different quantities. So this is an insertion that we performed, and here we represent the strain, which is negative, which means that we have a compressive strain along the axis of the catheter, and we expect that because since the catheter is 90-degree turn, it's likely bent during the insertion. And what we observe is that we have a peak of negative strain in proximity of crossing of the last layer, and then the strain rises as a result similar to the previous research done by the Sanyo group that shows an increase of pressure at the tip during the crossing of the final layer. What we were able to observe, however, in this experiment is, first of all, a match between FBGs and OBR data. which we perform in the time domain by plotting the result of some of the sensors that basically are located in the same location of the corresponding FBG and the 5 FBG data, and observing the strain patterns. As we can see, the strain starts to lower in a sort of gradient shape as the catheter progresses into the tissue. Here is the crossing of each layer occurring at each time, and then we observe the final rise. In a kind of comparative way, we can say that we have a qualitative analogy between the two trends, although the final strain rise is recorded better on the FBGs rather than OBR. This might be the fact that we could not pinpoint exactly the same sensing point because of the spatial resolution difference, tenfold difference between the two sensing technologies. Now, what happens in experiments that do not reach the epidural space instead? So basically, the catheter is blocked before. So what we observe here is that we do not have the lack. We have the lack of the final pressure rise. So this result is kind of similar to what the previous result reported. The lack of the pressure rise at the end can be correlated to the catheters stopping before reaching the epidural space. And that, I think, is an important information because it shows a certain analogy of behavior between what we are presenting and what are the other technologies that previously did that. So not reaching the epidural space can be verified by missing the final pressure rise. However, we can detect other type of events. For example, in this case, the catheter was rotated voluntarily by the person inserting the catheter, mimicking a rotation of the catheter in the tissue that the clinician might exert to push through a layer. What will happen is that by rotating, in this case we did a 180-degree rotation, which is fairly too much for a clinical procedure, but it kind of shows the pattern. We observe that basically the strain gradient reverses the sign. So a strain that started to go negative all of a sudden become positive. And for each sensor that has already been inserted in the tissue, we start to see the opposite bending. So we can detect rotations by a change of sign. In the strain map, in color maps, this looks like a reverse of the coloring of this waterfall chart. Whereas we have that the strain that was negative all of a sudden reverses sign. For example, when the insertion is performed at double the rate, and particularly accelerating the insertion of the final layer, in this case, we expect that the pressure rise is much larger at the end, due to the fact that the catheter tends to bend strongly at the tip. We can see that by an anomaly in the strain pattern, that is, that the final pressure rise starts to be much larger than in the previous insertion. And we also did several experiments mapping other type of events. We can see events such as the catheter that has been bent around the insertion, or the catheter that is bent outside and therefore resulting in a bending side. So we can detect several bending patterns. So in conclusion, we reported FBG-based and OBR-based technologies for detecting bending in epidural catheter with the intent of providing a guidance system that is not only able to tell whether the catheter has reached the epidural space, but also whether the catheter is going to reach it or is going to fail before the event happens. Data between OBR and FBG are in a qualitative agreement. The sensor detects strain gradients over time and space, which are tied to strain events that can happen during insertion, and the result is in analogy with the previous result done by Carlo and others in Sanio in Italy. So what we are going to do right now is two things. The first one is a neural network-based classifier that is able to interpret all the strain data that our eyes and probably our brain is not able to do at the same way, in order to be able to have a classifier that classifies multiple events that occur during insertion. And the other thing that we're going to do is to use fibers with a high scattering to perform a sort of scattering multiplexing and multiplex multiple fibers around the catheter. This way we are not only able to tell the strain directionality on one direction, but to map all the 4 cardinal points around the strain to be able to detect, for example, left bending between right bending, up bending toward down bending, and in general the change of temperature that occurs between the catheter insertion when the catheter starts from room temperature and progressively goes to body temperature. So that's enough. I would like to thank for the attention, and if there are some questions, I would be happy to answer.